welcome back to Visions for Health. I'm Dr. Wendie Trubow, and I'm delighted to have as my guest today Dr. Roseen. Eric is a doctor of chiropractic. Eric, welcome.
Thanks, Wendie.
Thanks for being here.
Yeah, thank you.
So talk to me. When was the first time you realized you were meant to be a chiropractor?
Yeah, so I was in high school, and I had always been interested in movement, and I had a really good biology teacher, so I was thinking something health-related. I was a wrestler since fourth grade, and I had an injury. I rolled over my neck during a tournament, and yeah, it was
Sounds painful.
It hurt. It hurt a lot, and it was scary, and I wasn't sure if I would be able to wrestle the next tournament, or I wasn't sure where I could return. But my coach, he said, you need to go see the chiropractor, which I had never really thought about it before. And he had me go, and one treatment I was much better, and two treatments I could wrestle again. So it was just very effective. And after that, I took anatomy class my senior year in high school, and I think I was kind of locked in after that. I wanted to be a chiropractor.
Do you come from a family of wrestlers?
No, I don't. My dad is, I'm probably like 8 inches taller than my dad, and I think he played some sports, but I'm bigger and maybe more athletic than he was. But don't tell him that. Don't tell him.
Never. But this is filmed.
Yes. So no, but
so you went to college, or you went right into chiropractic school? How does it work?
It works. So I have a bachelor's in biology and chemistry. So I did that first. So 4 years in Moorhead, Minnesota, and then I moved out to Oregon for chiropractic college.
Okay. And you're from the Midwest originally.
Yep. So I grew up in a town of 7,000 in it's called Devil's Lake, North Dakota. Yeah.
Got it. It's cold out there.
It is cold, and they've gotten many blizzards already. So.
Oh
yeah.
wow. All right.
Yeah.
I think it would be better to be a chiropractor there, possibly, with all the back pain.
Good. I mean, yeah.
And the shoveling.
Yeah, lots of manual work, but also people who sit all day have different occupational hazards. So, the desk job is quite common here in Boston, and people tend to have the same types of postural issues or neck pain. So, yeah, maybe not.
So what's the most common complaint someone would come to the chiropractor for?
Yeah, so there've been big surveys across all countries, and probably 40 to 50% of all visits to chiropractors are for low back pain. So by far, that's the number one thing that people see chiropractors for. It's a very common condition, but also people associate that. But some of the next common would be neck pain, and then third is headache. That's probably like an additional 30% of all visits, and then shoulder, ankle, knee, hip, kind of other musculoskeletal conditions.
So back pain's the number one?
Number one.
And then neck,
and then neck
headache?
pain, and then headache.
That's amazing.
Yeah.
I mean, these are things that people call out of work for, I think, that they can't get out of bed, their back hurts.
Absolutely. Low back pain is the number one cause of work-related disability. It costs, billions of dollars every year. And that's lost cost to a company, to an individual, lost productivity. They can't make as much if they don't have as many workers. So it's a big deal.
And you can help this
every day. I was treating patients this morning, and I think half of them or more were low back pain. And I really enjoy it because it's something that it is very common. But when you have an acute back pain or acute spasm, it's really painful and it's scary. And to be able to talk to people and say, these are the things you can do, this is how long it should last, is great. And most people do bounce back within a few weeks.
Okay, so one thing people have said to me is, I don't want to go to the chiropractor, they're going to crack me. Is every chiropractic visit associated with something cracking?
No. So the first visit to a chiropractor may not even include treatment. Sometimes it does, but primarily when you see a chiropractor, they're trained in full diagnostics. So they'll look at determining a cause. a diagnosis like any other doctor would. So if you're appropriate, you might have treatment, but if you're not appropriate, if there are any red flags, they might send you for imaging, or they might send you to a specialist if they say, this might not be something that I can help with. But most types of low back pain or most musculoskeletal conditions do respond to conservative care, so they'll kind of have a plan. And that may involve cracking, or it might not, but cracking is trying to get a joint that's not moving, so a spinal joint or a joint in the elbow or the ankle that's restricted and painful and tender, and trying to get it to relax and to move, have healthy motion. So you can do that through kind of stretching the joint, which is very light. It probably won't crack. And you can do it with more traditional techniques that will get it to release quicker and get a audible sometimes.
The pop.
The pop.
So what are the things that are not cracking that you do to relax people? Like, or I don't mean relax them, but if a joint is locked up and it's not moving and they either don't want to be cracked or you feel they're not ready, what do you do up to the cracking part?
So sometimes heat can help the muscles and the soft tissues around the muscle relax a little bit, and that is going to influence the joint's ability to move. Giving people exercises where they're working through a pain-free range of motion is also something that they can do themselves to help improve that range of motion. Getting in and putting pressure and stretching the joint passively is something that I often do first before I do anything else, to try to see, where is it most bound up, how do we stretch that area, and then you can add resistance into that, so the patient's maybe pressing a little bit to help add a little stretch to that passive stretch, and then really the traditional adjustment it's called a high velocity, low amplitude. So you're not going deep at all. You're just going millimeters in depth, but you're doing it very, very quickly. And you're trying.
This is the adjustment, or
this is the adjustment. So there's kind of this workup of different techniques that are very gentle, feel very nice, to techniques that still can feel very nice, but maybe if you've never had it before, might seem a little odd if it's your first time. So I often work up people. And there's like a spring-loaded tool that's a very reliable force. It's very gentle. It's called an activator that you can be specific in for people who have low bone density and are nervous about one of the other types of techniques. We might use that instead as well.
Okay. Do you have one of those?
Yes, okay. I have one of those.
Okay. Now, do you have other certifications or other tools in your toolbox, like additional things that you've done to do muscle release? Yes.
So soft tissues, so muscles, tendons, ligaments, nerves, and kind of the saran wrap that wraps everything together, fascia, really can cause stiffness and cause pain. So I think that treating those elements of the body are really important too. And I probably spend most of my time working those tissue. It's more time intensive. So if I see someone, probably 80% of the time is just working on the soft tissues. And I have a couple certifications. One's active release technique. It's commonly known as
what is that
ART. And it involves, a muscle has a full range of motion, and at one part of the range of motion, it's in a very short contracted position, and in another position it's kind of maxed out, it's stretched out, and it's in its longest position. And if there is what we call an adhesion in that muscle, kind of like a patch of scar tissue, that might bind up the muscle or stick it to another muscle, and it won't be able to stretch out fully. So active release technique is taking it to that shortest position, trying to find a potential adhesion, and then stretching it through its full range of motion to try to release that adhesion and regain movement, the full range of motion.
What does the adhesion feel like when you have the muscle contracted at the shortest point?
It could feel like just an increased density. It could feel really firm, kind of like you've rolled over a pebble. Actually the other certification I have is Graston technique, and why that's a little different. It's actually a stainless steel instrument. There's 6 different instruments, and one is like this kind of bar, maybe about that long, and you kind of work through the tissue, and tissue should feel soft and supple, and that really resonates through the tool. So it's diagnostic primarily, and if a muscle's in spasm or if it's shortened over time, it'll feel firm, and if there's an adhesion, it'll feel like you're rolling over a bump.
So you use the 2 things together?
I often use the 2 things together.
Okay.
And I can really feel the adhesion with the Graston tool, which is nice.
Okay, so you're using the ART to find the area of imbalance, I would call it, and then you're using the Graston tool to release it. Is that proper?
So both release it. So you can look at someone, if they can't raise their arm above their head or they don't have full range of motion at any other joint, you think that, there could be an adhesion. Let's try to find out where it is.
Is it usually injury related, or is it simply life or age?
It can be from a chronic injury. There's a few different examples. One would be if you, it's a pretty straightforward example, if you tore your biceps, the area that it heals there's going to lay down scar tissue there, and it's going to take a while to heal. And if you don't have full range of motion in your bicep, then there's probably adhesions or scar tissue that are limiting that range of motion. So getting in there with the tool would you potentially release that. But also any area that's had inflammation, scar tissue is laid down in tissue that has more inflammation. So if you have postural strains, or you're at a desk job and you're always sitting kind of forward like this, it's a lot of strain on those muscles, and you might have a little inflammation, and that might lay down patches of scar tissue slowly. And scar tissue, it's a normal process, but it's not as flexible as healthy muscle tissue. So that's why it feels stiff, but not necessarily painful, and over time it may become painful.
So you just mentioned people who work at desk jobs, and Boston is pretty rife with desk jobs.
Yes.
What are your recommendations for people who sit at a desk and want to maintain good posture, or feel as though, oh yeah, I have some stiffness in my back or discomfort over time?
So great question, and I think a lot of people really struggle with this because it's not easy. So I think the first thing I would say is we were not meant to sit for that long. I think it's good for us to know that. Yeah. So the first thing I would say is every half hour, or certainly every hour, trying to stand up, go to the water cooler, do something that doesn't take a lot of time, but make sure you stand up periodically.
So move regularly.
Move regularly.
Tip 1. Okay.
And then the other thing is to make sure that you are checking in on your posture and are mindful of your posture. So maybe every half hour or every hour, you're kind of sitting up, your chest is rising up, and as your chest is rising up, your shoulders are dropping down and maybe back. Often I'll hear people say, it's a good posture if you're squeezing your shoulders together and like you're pinching a pencil between your shoulder blades.
Let me try this.
And I actually don't think that
feels a little uncomfortable.
I think that's too much. It's too aggressive.
Yeah.
What you're trying to accomplish is to inactivate or use other muscles and not use your upper trap, which are these muscles. So by really focusing on bringing your chest up and your shoulders down, you're going to activate the muscles below your scapula to kind of gradually bring your scapula and your shoulders down and back. So I think, lots of breaks, practicing this posture, and then there's a number of exercises that I give people that kind of work off this foundational posture so that you actually get strong in this position, and it's something that you're used to. So
what about when you're actually at the desk? Is there, I don't know if you know the answer to this, is there a certain height that your hands should be at? Is there a certain height the arms of your chair should be at? How about the height of your chair relative to your desk? Are these things that have been studied?
Yeah, and it's the literature is very confusing, and I would say that it's definitely a trial and error. Like I had a patient this morning who, we've been working on her low back, and she's moved from a sitting desk to a standing desk, and with that, her back is getting better. It's really helping her low back to make that transition, but she's moved her computer or her screen, and now she noticed this last week that she's looking down slightly at her screen. So now she's getting some neck tension. So as you move from one position to another, there are its own challenges, but making sure that you're looking at the screen, that your arms are supported, but that your shoulders they're not so supported that your shoulders are in your ears, that there maybe if there's a lumbar support or a curve that supports your back a little bit, but not pushes you into hyperextension of the low back. So it is something you need to fine tune and trial and error, but it really makes a difference.
Okay. And should your feet always touch the floor?
Yes.
Okay.
Don't want to hover.
No hovering?
No hovering.
We're not helicopters?
No hovering.
Okay. So your feet touch the floor, your arms aren't up high.
Yes.
Typing? I really don't know the answer to this. Hands higher, hands lower?
So if you go too high, you're gonna kind of compress the wrist a little bit, and that's how people get carpal tunnel. So a neutral wrist is really good. So having maybe a gel pad, something on your palms, so you're typing in a neutral wrist that's supported both at the wrist, and you're using your typing, so that's pretty balanced. For a mouse, if your mouse is kind of further away, you're going to extend your shoulder, and a lot of people will get kind of shoulder or shoulder girdle pain between their shoulder blades. So making sure that that's relatively close to you, if possible.
So that your elbow is relatively close to your body,
basically. So you're not kind of reaching for your mouse.
Okay.
And then, some people do prefer a it's an odd shaped mouse, but instead of having your hand fully turned over, you're actually like this.
Okay.
That's because that's more of a neutral wrist versus, again, kind of compressing the wrist in this position.
Okay. Now you mentioned computer height with your patient, or screen height.
Yes.
So should your screen be, how do you figure out how high to put your screen?
If you're doing this posture where you're sitting upright, you should be looking straight at your screen. You shouldn't have to tilt your head up or tilt your head down.
So the middle of your screen is where your eye level is?
Eye level is, yeah.
Okay. I think I have to go home and look at the height of all my computer screens. I think they're too high or too low.
Yeah, it's good.
All right. So talk to me about who's the best candidate for chiropractic. Is it a kid? How do you treat children, or is there an age, a lower limit, and is there an upper limit?
Yeah. So I usually treat people for for my scope of practice is quite large. There's a lot of different reasons that I might see someone. So children, I think, one really practical way that I've worked with children is they struggle with posture, and they're carrying backpacks, and maybe they're pulled forward, or they slump a little bit. So I've really done a lot of education with patients. We do some treatment with that age group, kind of teenagers, but really it is about getting people to be comfortable in this position and teaching them how that's important and how they can make this stronger. I see a lot of athletes. I was a college wrestler, so I really relate to that population, and I've done a number of races, including a marathon. And I've worked the Boston Marathon. I really like that population. So that may be back pain, maybe a knee injury or a ankle injury. And then, the desk job population that's trying to, find a balance and getting, enough exercise and taking care of their kids and making sure their posture is as good as possible. But like most chiropractors, low back pain, neck pain, and headache are the things that I see every day, and I'm really good at treating. I really enjoy treating those things.
You just mentioned exercises. Do people get prescriptions to minimize their inflammation, eat better, sleep more, stress less, and exercise? And in the exercise, are you giving people specific things? Do this, don't do this? Is that?
I am, depending on what their injury is. If it's maybe they've had a disc injury or they have an active disc injury, if they do a lot of forward flexion, that might put more stress on the discs. So they might want to avoid certain lifting activities or rowing. So yeah, there are some basic things to avoid for certain conditions.
Right.
But most of the time I find myself telling people that they can do a lot to their tolerance. People are often scared to move because of the injuries that they have or have had in the past. And that really, kind of locks people in, and they become, their core becomes weak, and they actually end up having more pain because of this fear avoidance to exercise. So I find myself just encouraging people to do something to try to hit 150 minutes a week, which is kind of the national recommendation, and anything beyond that is fantastic. And then to find something that they really enjoy, because if it's running, that's fantastic. If it's dancing, if it's doing anything where your body is moving, that's exercise. And if you do it 10 minutes or more at a time, that's exercise. So if you're doing a walk in the morning, if you're doing a walk at lunch, and if you're doing another 10-minute walk, when you get home, that's 30 minutes a day. And if you do that 5 days a week, that gets you to your 150 minutes.
So you can split your exercise, and there's no problem.
Yeah, and some people don't feel that. I mean, they think, if I only do 10 minutes, that's not enough. I need to do 2 hours of exercise. I need to lift a lot of weight above my head.
Yeah.
And it's not true. To get the all of the benefits of exercise, which there's so many, you just have to do light to moderate exercise on a regular basis.
Now, you mentioned movement. You have a return to movement program, correct?
I do. We've been working on starting that, and that's it's something that I'm really involved with the American Public Health Association, and that's kind of beyond low back pain. That's another thing that I'm really interested in, is this idea of physical activity or return to movement. One, identifying why people don't, if it's the busy schedule or they're afraid of it, and then trying to find ways that work for them, and that might be hooking them up with a yoga studio or a personal trainer, or just talking through what they can do in at home or at work. So yeah, I'm very interested in that.
Seems like if you're out of practice, that first hurdle is to just start.
Yes.
Just like, what am I going to do, and where am I going to do it, and how long am I going to exercise for? That seems like it's probably the thing that gets in most people's ways. And also for women, what am I going to wear when I'm going there?
Yeah, I mean, those are all, we like to overanalyze everything, and we live in a very smart, very analytical city, so people want to plan every detail out, and there's nothing wrong with that. That's fine. But if it's holding you back,
right,
you might want to simplify things a little bit and just move.
All right, talk to me about the core. Do you find that the core is related to back strength or back pain? Are they connected?
Certainly can be. There's kind of the most evidence-based approach to low back pain would put people who have low back pain in different categories. There's one category that's stenosis or a disc herniation. Those two categories are specific low back pain. That's like less than 5% of all low back pain. So what you get is this other group of low back pain, which is it's maybe muscle, tendon, imbalance, different pain generators that usually respond really well. And you can break that into categories of, core weakness is one category. So I would certainly evaluate everyone for that. People who have a new episode of low back pain, people have a bias. When they flex forward, it feels better, versus if they extend backward, it feels better. Usually you can find one direction that actually makes their pain better. So if you can fit someone into one of those 4 categories or multiple of those categories, they get well or get better quickly.
With core exercise, or
if they need it.
Okay.
Some people can have a really strong core, and that's not what they need. Okay. But I would, I see it often. It's very common, and that's again tied with getting people back to exercise, and then maybe giving them specific exercises like a plank or...
Those are hard to do.
They're hard to do. They're hard for the core, which is good. It's challenging, but that's actually not that much stress on the spine. So someone, once they're out of pain, they can do it relatively soon without putting pressure on their spine, which is maybe what they're worried about. And they can gain strength pretty quickly.
Can people start up against a wall doing a plank? Does that make any value?
They can start on their knees.
So they can
start
work
on
up
their
to full plank.
elbows. Yeah, there are progressions. And if you get to a full plank and it's too easy, then there are progressions. You can do it on an unstable surface. There's one of my favorite exercises called stir the pot, where you do a plank on a medicine ball and you do circles, or on an exercise ball and you do circles. And it's the most challenging and without putting much stress on your spine. It's a very high quality exercise.
That sounds very cool.
Stir the pot.
I don't think I could stir the pot.
It's tough.
It sounds hard.
We should have a stir the pot challenge. See who can stir the pot.
I think you would win the stir the pot challenge. So we're beginning to reach the end of our interview. Is there anything that I've missed asking you that you would say, oh, we have to mention this, or anything in that realm?
I think we've covered all the things that I do most often. Just to give maybe an example of, to run through what it would look like for a patient to come in. I think that's useful. So someone comes in, it's always the evaluation first. Try to find a diagnosis. One thing that being at Visions is really nice. We can really coordinate care with the primary care doctor or with the other people that they're seeing to. So if someone needs more than what I have to offer, if they need some medical management, they can get that. If they want to combine chiropractic with acupuncture or chiropractic with yoga therapy, that's very good too. And then we have that conversation and we come up with a treatment plan. And it's a treatment plan is one of the most common treatments plan is once or twice a week for 2 or 3 weeks. So you're getting this kind of 4 to 6 visits to see if this is something that's effective, and many people are better by that 6th visit. And if they're not, we say, maybe you need something else. Maybe you need further evaluation. And I think that model works really well because they have so many resources when they come to Visions, and we really try to get them what they need.
Is this usually covered by insurance?
Every major insurance company has a plan that covers it. I think about 75% of plans have a chiropractic benefit. Medicare has, all Medicare patients get 12 visits a year.
So it's often something included?
Most often covered.
Awesome.
But not consistently from company. Someone might have 12 visits a year, someone might have 60 visits a year. So there's kind of a big variability on what it actually is. Very
cool. Eric, thank you so much for joining us for this interview. Thanks for joining us. You've watched another Vision for Health episode. This is my guest, Roseen, Doctor of Chiropractic. Thanks for being here.
Thanks, Wendie. Great.